So good afternoon, everyone. Welcome to this first session of the Friday ICM teaching in this year. Today's topic is going to be on aneurysmal subarachnoid hemorrhage. I'm Dr. Ravindra Pochiraju, recently joined as a local consultant in intensive care at the LRI. So this is an important topic for all of us who work in both centers which don't deal with neuro emergencies and who do work in places where there are neurointensive care units, because we keep seeing patients who present with subarachnoid hemorrhages every now and then in the ED. So why is it important? It's a worldwide health burden. The UK incidence is about sort of 6 to 12 people for every 100,000 per year. But the devastating thing is that majority of the patients who have this problem are young. It comprises 5% of all the strokes, and the mortality was about 50% a few years ago. It's dropped down to about 35%, but it is still very, very high. And the most sort of distressing thing is that about 25% of the patients can die before reaching the hospital if they had a sort of significant subarachnoid hemorrhage. It's a complex neurovascular syndrome. It has profound systemic effects, and it affects sort of not only just neurological systems, but also cardiovascular, respiratory systems, and has profound sort of fluid electrolyte imbalance issues as well when you're dealing with these patients. It can cause devastating early brain injury, as well as also causing quite profound delayed neurological deficits going on even when the patient manages to survive the initial insult. The rates of permanent disability are also quite high, again, in patients who have survived the initial bleed. To make the best of outcomes in these patients have to be managed in a neuroscience center where multidisciplinary approach to sort of tackling these multiple issues in these patients becomes very, very important. Most of the subarachnoid hemorrhage by itself can be caused by trauma, but today we are dealing about aneurysmal subarachnoid hemorrhage, which by far is the most common cause is from a ruptured aneurysm. So 80 to 85% of cases of traumatic subarachnoid bleeds are due to a ruptured aneurysm. The aneurysms by themselves can be sort of silent. You do see them sort of in patients when you sort of scan them for other reasons, and they can be sort of secondary to some congenital or acquired condition. And in terms of who gets these aneurysms, there is a list of factors. So patients who've got family history of sort of aneurysm ruptures in their sort of first to second degree relatives, patients who've got connective tissue disorders like Marfan's and Ehlers-Danlos, and patients who've got polycystic kidney disease, the incidence of aneurysm formation in these group of patients is quite high. Again, for some reason, aneurysm formation, aneurysm rupture is again more common in women. The peak incidence is about sort of, the ballpark figure is about sort of 50 years, so it's anywhere between 40 to 60 years. So it does affect sort of young patients, which is why it's such a big problem. So where do these aneurysms form? So before we go into that, it's useful to understand the sort of just briefly about the blood supply of the brain. We all know about the circle of Willis, and it's sort of formed by the combination of branches from the internal carotid artery and branches from the basilar artery. So the two internal carotid artery, once they enter the brain on the right and the left side, they divide into middle and anterior cerebral artery, and the two anterior cerebral arteries of both sides, they are joined by an anterior communicating artery. So taken together, the middle cerebral artery, the anterior cerebral artery, and the anterior communicating artery, they form the anterior circulation of the brain, and that's where about 75% of aneurysms are located. Coming to the posterior half of the brain, the basilar artery gives rise to the posterior cerebral artery, and then there is a posterior communicating artery which joins the posterior cerebral artery with the anterior circulation. So the posterior cerebral artery, along with the posterior communicating artery forms the posterior circulation, and that sort of accounts for about sort of 20-25% of aneurysms location. Again, in terms of why this is important, because the treatment modalities can differ whether the aneurysm is located in the anterior or the posterior circulation. And again, for some reason, the posterior circulation aneurysms are more prone to rupture. So as we see in this figure, and about sort of 75% of aneurysms are in the anterior circulation, around 25% are located in the posterior circulation of the brain. In terms of why the aneurysm forms in the first place and why it ruptures, so whenever the cerebral vasculature, the arterial circulation, it starts to divide and branch up, at the branch points, it is seen that the tunica adventitia layer gets weakened, and it is prone to formation of aneurysm. And so where sort of internal carotid artery, for example, divides into middle cerebral and anterior cerebral artery, as we see in this figure in panel B, that's where the arterial vessel wall is weakened, and that can give rise to formation of aneurysm. Most of these aneurysms, they can remain silent until they rupture. Most of the aneurysms are saccular. The ones that rupture are usually saccular or baryoaneurysms in 90% of the case. About 10% of aneurysms are fusiform. Again, the reasons for fusiform aneurysm formations are usually related to sort of hypertension or atherosclerosis or dissection. So why the aneurysm ruptures? So it's usually associated with a sudden increase in cerebrovascular arterial pressure, which leads to rupture. And once the aneurysm ruptures, the blood sort of percolates into not only the subarachnoid space, but it also goes into the parenchyma of the brain and also into the ventricles. And that in totality gives rise to a situation wherein we've got significant intracranial hypertension. And in terms of who is prone to aneurysm rupture, so people who sort of are smokers, current smokers, who abuse sort of drugs like cocaine, alcoholics, patients who've got issues with alcohol excess, aneurysms which are more than sort of 7 to 10 millimeters in size, females more than 50, and patients who are hypertensive. In all these patients, the aneurysms are sort of more prone to rupture. So this is just I've just sort of shown the circle of Willis again and put a picture of cerebral angiogram just to show that the way that the aneurysm here is forming in the angiogram on the right, wherein it's forming at the place where the internal carotid artery is sort of dividing into the anterior and middle cerebral artery. And just to compare that with the picture of the circle of Willis on the left. So in terms of how to diagnose the patients who've got these cerebral sort of catastrophes from subarachnoid bleeds. So the main sort of clinical features that these patients present is with what they describe typically, and we all know that is as they describe it as the worst headache of their life, and it is typically described as a thunderclap headache. Associated features can be they can have various features of meningismus like nausea, vomiting. They can have photophobia, neck stiffness, and most importantly, altered neurology. And as we'll see later, altered neurology is one of the sort of main factors which sort of guides the prognosis of these patients. In about 30 to 40% of patients, there is a episode of sentinel headache, which is quite difficult to diagnose. Very often it is missed in ED because about 1 to 2% of patients that present to ED have headache, and it is quite difficult to diagnose sentinel headache. So a detailed history and sort of assessment of risk factors for those patients can be useful in delineating whether the headache is due to a subarachnoid bleed or otherwise. So as always, when you're dealing with patients who've got a possibility of a subarachnoid bleed, you're going to synchronously sort of resuscitate the patient whilst at the same time trying to find out the cause of this undifferentiated neurological emergency. So you're taking a good collateral history, doing a good physical exam with focus on neurology, and also asking for neuroimaging at the same time. In terms of diagnostic modalities to identify a subarachnoid bleed. By far, CT is the best, easy to do, and it's almost sort of 100% sensitive when it is done in the first 24 hours. The sensitivity tends to drop after 3 days, but up until then, CT is still by far the easiest way to diagnose subarachnoid bleed. And very often, as we all know, when we spot a subarachnoid bleed on a CT, we often sort of do a CT angiogram as well at the same time to sort of detect the aneurysm and find out the cause of subarachnoid bleed. If in any case the CT is negative, then there are other diagnostic modalities that can be done, and then we're left with the choice of options between either doing an LP or an MRI. MRI, for sort of the reasons that we all know, it's logistically difficult in a patient who is obtended with a low GCS, but it is sensitive. But I wouldn't want to be in an MRI scanner in a patient who's got subarachnoid bleed with sort of unprotected airways. So that makes it difficult in that sense. But it can be done, and it is sensitive, and it is useful to diagnose. Coming to LP, lumbar puncture, in patients where the CT scan is negative, you can actually diagnose subarachnoid bleed with a lumbar puncture. But then what we're looking for in lumbar puncture is the evidence of xanthochromia, evidence of the big breakdown products of RBCs into bilirubin, but that takes about 12 hours to happen. So you get the best results from an LP to diagnose subarachnoid bleed after around that sort of time frame, which is about 12 hours after the sort of initial presentation. Having said all of this, digital subtraction angiography is still the gold standard of sort of diagnosis in terms of locating the aneurysm and also making further plans about sort of treatment and in terms of whether you want to clip or coil the aneurysm. In addition to all the neuroimaging modalities that I've just described, when you're sort of dealing with these patients, you also it would also be worthwhile asking for other investigations like a chest X-ray, an ECG, a troponin, asking for a bedside echo and a tox screen, because subarachnoid bleed, as I've said before, has profound systemic effects, which has implications from a respiratory and a cardiovascular point of view as well. So just sort of a quick note before we go ahead in terms of what we're looking for in sort of lumbar puncture and CSF analysis. So these are sort of two tubes with CSF. The one on the left is the one which is yellow in color, which is exactly what the CSF, which has xanthochromia, it looks like. And I mean, if you see it once, it's difficult to sort of forget that that is what it looks like. What you're actually seeing is you're doing a lumbar puncture, doing a CSF tap and collecting about 4 to 5 bottles of CSF. And then what you're saying is if it is an atraumatic tap, you should not be seeing any red blood cells in the 4th or the 5th sort of bottle of CSF. But if it is a subarachnoid bleed, that RBCs will still persist. And again, you can actually compare the tube containing the CSF against, for example, clear water, and you should be able to actually delineate the color difference between the two samples. If you want to be more sort of specific in diagnosing this, you can do spectrophotometry of this sample, but I don't think that's available in all centers, and in majority of the centers, you just have to do sort of visually inspect the CSF sample against a sample of probably clear water. So before we go ahead, we just sort of look at few images. I mean, I just wanted to know if you can actually sort of briefly report the scans on the left. You can either shout out or put it on the chat window on what you're seeing in the first two sort of CT images on the left.
So one of the guys here has made a very educated guess of subarachnoid blood, which I think is
that's good. That's good for a beginning.
I made the educated guess that those stars shouldn't be there.
Yeah, that's good as well. But what I'm more keen to know is why is that sort of star there in the first place? What are we seeing there in that sort of first CT scan image?
Someone said blood in the ventricles.
Well, I can't see any blood in the ventricle in the first CT scan. Probably a trace of blood, but there is something more important that we all need to identify.
I think loss of volume was shouted out from the back as well.
Okay.
There's blood in the insula. Yeah.
Any from the Royal?
Blood in the insula?
What's that? Sorry.
The insula of the parietal lobe. This one or this one?
What's the most obvious thing in the first CT image that you see where the stars are located?
The volume of this one's the right. The volume of the ventricles are not equal.
Yeah. So, what can you say about the volume of the ventricles?
Pressure effect maybe, or something like that, or closure some point.
Are the ventricles normal or abnormal in that first CT image?
It's not abnormal. There's a level here.
It's not abnormal, is it?
Yeah, it's not normal.
It's not normal. Yeah, exactly. So that's a dilated temporal horn of the lateral ventricle, which you should not actually see in a normal CT scan. It's not visible. So the two sort of stars are exactly located over the sort of temporal horns of the lateral ventricle, and that signifies a patient who is developing hydrocephalus. Likewise, there is some subarachnoid blood in the second CT scan as well. And then the last picture on the right, it's a CT angiogram which shows a basilar top aneurysm. Okay. Oh, what's happened to the? Yeah. So can we sort of interpret these CT scans? Again, starting from left to right. What's there on the first CT scan on the left?
Interventricular bleed, and there is bleeding in the. I think it's in the sulcus between the temporal and frontal lobe.
Yeah. So there is subarachnoid bleed. It appears to be sort of densely located in the sort of basal cisternal area. Again, I mean, the reason I'm showing these scans is that we need to be aware of the fact that we are not expecting to see any temporal horns, and if we see that, that is an evidence of hydrocephalus and possibly raised ICP. So in the first image on the left, there is blood in the lateral, in this ventricle here. If you can see my arrow,
Yeah.
there is, and the arrowhead points to presence of subarachnoid bleed, which is again the basal cisterns, and again you see a dilated sort of temporal horn of the lateral ventricle. What's this sort of thing here? What could that be?
This is the basilar artery, I think.
Well, that's blood in the fourth ventricle. So there is significant intraventricular hemorrhage in this CT scan, and it's a high-grade subarachnoid bleed. The second picture is just to sort of put that in perspective of why sort of anatomy of circle of Willis is important, and they've just sort of shown how the sort of arteries divide and form the circle, and where the aneurysms have likely ruptured in this in the patient with this CT scan. And the last one again shows an aneurysm which is shown with this arrow here, and that's it's a CT angiogram showing an aneurysm at the level of posterior cerebral artery. So going forward, once you sort of know that the patient's got a subarachnoid bleed, you've done a CT scan, you've imaged, you've done sort of CT angiogram. It's important to sort of grade the severity of the subarachnoid bleed, and the grading is useful because it tells us the prognosis of these patients on whether they're going to get better from this. Are they going to sort of survive the insult of the subarachnoid bleed, and also to sort of predict the outcome from a subarachnoid bleed. So in terms of grading for subarachnoid bleed, there are around sort of 3 to 4 systems that are commonly used. The ones that we ought to know are the WFNS grading, which is the World Federation of Neurosurgical Grading. The other one is the Hess and Hunt grading, and then the third one is the CT grading, which is also called as the Fisher grading of subarachnoid bleed. These 3 are the most commonly used, but obviously when you look at the Hess and Hunt grading, there are sort of lots of descriptive terms that are used in that sort of grading. So it says sort of slight nuchal rigidity, severe headache, mild deficit, moderate to severe hemiparesis. These are all quite descriptive terms, so you can actually straddle grades depending upon who is interpreting the scans. So most often neurointensivists, neurosurgeons, they resort to the WFNS grading, which is more sort of an objective way to grade these patients according to the presence, whether they've got motor deficit and what their GCS is. But obviously, if you're using a WFNS grading, you need to get your GCS right. That's the caveat with that, but that's probably more objective when compared to the Hunt and Hess grading. In terms of Fisher grading, so those are the 4 CT scans which show the 4 grades of subarachnoid bleed as per the Fisher grading, starting from the panel A where there is no bleed at all, going to sort of panel 3 where there is a large volume subarachnoid bleed, which is more than, which is sort of quite thick. And then the last panel on the right shows significant sort of intraventricular bleed as well, which is sort of grade 4 in terms of Fisher grading. And so how are you going to manage these patients? So when any of us sees these patients in a center where there is no neurointensive care, we still have to stabilize the patient, and it focuses on sort of achieving cardiorespiratory stability, medically stabilizing the patient with an ABCD approach, controlling ICP, but the emphasis is on preventing secondary brain injury, so preventing hypoxia, preventing hypotension, and most important is to prevent rebleed. So if you happen to see these patients in ED and you're wondering whether you want to intubate or not, again, if there is a doubt and if you're not sort of happy with the GCS of the patient, and if this GCS is less than 8 or there is more than 2-point drop in GCS whilst you're evaluating the patient, that patient is likely to deteriorate and should have a low threshold to intubating them. Obviously, you are going to have a discussion with neuro centers as well and see what they want you to do. But if you're not happy with the patient in terms of GCS and the GCS appears to be fluctuant, it's possibly safe to err on the side of intubating these patients. Again, if the patient is not able to protect and do not their airway and do not have intact laryngeal reflexes, as in any other case, always intubate. And again, the other reason for intubating these patients could be if they're presenting with seizures, and if you want to control the seizures, you do have to intubate them. And again, if you want to optimize their cerebral perfusion and oxygenation, it can best be achieved by intubating these patients. So what are your targets in terms of maintaining your PO2s and PCO2s? As we all know, and we use them very often, neuroprotective ventilation is what is most important. So you're targeting a PO2 in the range of sort of 13 kilopascals, PCO2 of 4.5 to 5, so normocapnia. Again, the emphasis should be when you're dealing with these patients at this level is to prevent the dam from bursting again. So you don't want a rebleed to happen at that time in a patient who already had an intracranial catastrophe from an aneurysm rupture. So maintaining systolic blood pressure of less than 160 millimeters, around that ballpark figure, is important. You can use antifibrinolytic agents like tranexamic acid or sort of aminocaproic acid. Again, their use is best sort of reserved to short-term measure when you're sort of dealing in the sort of very acute phase of these patients. If the patient appears to have any coagulopathy, like for example, if the patient is on warfarin or they've got deranged coagulation, by all means give them vitamin K. Again, giving them blood products like prothrombin complex concentrates and FFPs becomes vital if you have to correct the coagulopathy in someone who's got deranged sort of INR or APTT ratios. If the patient is on any antiplatelet medications for some other reason and has a subarachnoid bleed, there's no sort of hard and fast rule on whether you have to give platelets or not, because platelets by themselves are not sort of, they're not with their own sort of, they don't come with without any side effects of their own. But if dealing with such a situation, it's best to sort of consult the neurointensive care team or the neurosurgeons. And if the patient is going for an intervention, it's probably prudent to give them a unit of platelets at that point in time. Again, if the patient is not intubated, always sort of use anxiolysis and pain medications judiciously. What you don't want to do is over-sedate a patient who is not protecting their airway, because you need to sort of be able to sedate them judiciously to effectively do neuroobs on them. So by far the most important thing which helps in managing these patients is that they are best managed in centers who are high volume neurocenters. So they see about sort of more than 35-40 subarachnoid bleeds every year. And there are lots of nuances in managing these patients. And these patients are always best managed in places where they see them more often, where they can identify the complications earlier when compared to sort of other places where they don't see them that often. And that has been shown to improve outcomes as well. Again, this is something which we are all familiar with. In terms of in addition to medically stabilizing the patient, you also have to manage intracranial hypertension, which can happen in these patients. So all the neuroprotective measures like sort of maintaining head of bed elevation, normoventilation, normothermia, normoglycemia, hyperosmolar therapy, if that is what is needed, maintaining euvolemic status, prevention of fever, seizures, they all sort of become very important, and they are no different from any other intracranial catastrophe outside of subarachnoid bleeds. So those principles do apply in the acute phase in subarachnoid bleeds as well. So coming to the specifics of managing these patients who have a subarachnoid bleed, by far the most important thing is to prevent a rebleed or a re-rupture. It is the most feared early complication, occurs in about sort of 15%. There is a 15% risk in the first 24 hours. And if the rebleed happens, then it is associated with poor prognosis. It is bad. And the risk factors for rebleed are, again, female sex, patients who have had sentinel bleeds who have been missed, a poor grade subarachnoid like grade 4, grade 5 on the WFNS scale, and giant aneurysms. They're all sort of at risk for rebleeding. So the best way to prevent that is early treatment of the rupture aneurysm. So you're securing the aneurysm as early as possible and as early as is feasible. So ideally within 24 hours, but there are studies which have compared 24 hours versus, which is ultra early, sort of securing the aneurysm versus 72 hours. But anything less than 72 hours is preferable. Again, before you secure the aneurysm, it is important that you avoid any sudden decrease in intracranial pressure, avoid hypertension, and then sort of provide optimum sedation and analgesia to these patients. In terms of how best to secure these aneurysms, the main two modalities are coiling or clipping. Clipping is something which has been done for a long time. It's an open surgical approach, it's definitive management, but then it is quite invasive as well. Coiling, that's sort of more recent than clipping, and there have been sort of trials which have compared coiling versus clipping. By far the most prominent of the trials is the international subarachnoid aneurysm trial, which was again sort of quite old now, but then that's actually changed the way that these patients are managed. So the trial actually it randomized about 9,000 patients with intracranial bleeds from subarachnoid hemorrhage, and they have screened 9,000 patients, but they've only randomized about 2,000 and odd patients. And the main thing that they did in this trial was that the patient should have an aneurysm, and there should be clinically equipoise in terms of how they're going to manage the patients. So they should be equally amenable to both coiling and clipping. But what they found out was that the survival at 1 year and survival free of disability was significantly better with endovascular coiling. There was some evidence of early risk of further bleeding with endovascular coiling, but the late risks were not that high. Having said that, there are lots of caveats with this aSAH trial. The most prominent of the criticism is that it possibly recruited a lot of patients who were good grade subarachs. They've randomized a lot of patients, but only selected few with good location for aneurysms, which was amenable to either clipping or coiling. So they did not include the patients where the aneurysm were located in difficult to access locations. So you can't generalize the findings of the aSAH trial into all the patients with subarachnoid bleed. The other trial that is probably more recent is the BRAD trial. Again, that also showed that the endovascular treatment is beneficial, but there was no difference in groups. But what it boils down to is how the practice is in the center where you're referring these patients to. So if, for example, if it's a young patient with a giant aneurysm, with a broad neck and a low neck to fundus ratio, or terminal aneurysm, they're all probably better off being managed with clipping rather than coiling. But if it's a poor grade subarach in older age groups, then you're probably better off going with a minimally invasive approach with coiling. And that's more or less what the aSAH guidelines is as well, in terms of what to opt for in terms of clipping or coiling. So this is just a picture to show. On the left, you've got the patient. So what they do is that they cannulate the femoral artery, and then they super selectively catheterize the cerebral arterial circulation and locate the aneurysm and place the coils within the aneurysm. Whereas clipping is a more open approach. It's a craniotomy, and then you locate the aneurysm, isolate it from the surrounding circulation, and place clip whilst you're dealing with the aneurysm. Okay, so this one on the this is a CT angiogram. So on the left is a basilar top aneurysm which has ruptured, and on the right is the same aneurysm after the placement of a coil. So, okay, so can anyone interpret this CT scan? What does this show in the context of a subarachnoid bleed?
Can't see anything.
There's a coil between coils. That's where you have the artifact.
Yeah. So this CT, yeah, exactly. This is a CT scan in the context of a subarachnoid bleed. You can say that possibly this patient either had a clip or a coil, and there is a lot of scatter artifacts seen on the CT scan, which again we should be aware of when interpreting these CT scans later on. In terms of other management practice for these patients who present with subarachnoid bleed, as for any other general intensive care patient, good housekeeping is of paramount importance. So as for any level 3 patient that we do in the ICU, fast hug approach, maintaining a normoglycemic state, treating anemia, which can happen in 40 to 50% of these patients, and targeting a hemoglobin of 80 to 100 is important. Maintain euvolemic status, always. I mean, hypotonic fluids are bad anyway, but they're worse for patients who've had a brain injury. Optimum management of fever, again, which can happen in 70% of patients, is always important, because fever by itself has a cumulative burden in terms of increasing in mortality, increasing disability, and making the outcome poorer than what it should be. So always aim normothermia, and if you need to treat fever, and you have to treat it aggressively if it's not being controlled. And when you face a patient with subarachnoid bleed who has a high temperature, it is important to sort of delineate whether it's an infectious or a non-infectious cause, but always rule out infectious causes. And again, the causes are same as in any other ICU patient. So usually catheter-related bloodstream infections, VAPs, and in the context of someone who's got a neurological catastrophe, if they've got an EVD, you also have to sort of look after that aspect and do CSF surveillance and see if there is a situation like a ventriculitis developing because of an AVD infection. There is about sort of 1 to 18% DVT incidence in this patient cohort. So DVT prophylaxis is important, but then you're caught between sort of mechanical and pharmacological prophylaxis. It's not safe to use any low molecular weight heparin whilst the aneurysm is still unsecured. So in that context, you should use a combination of TEDs, flotrons. But once you've secured the aneurysm with either a clip or a coil, and in consultation with the neurosurgeons, it is safe to start them on DVT prophylaxis about 24 hours post clipping or coiling. So attention to detail is what makes most of the difference in these patients. And as I said earlier, the nuances of all of this is probably best managed in a neurointensive care unit. Coming to the complications of subarachnoid bleed, the complications can be neurological or non-neurological. The various non-neurological complications are hyponatremia, cardiac issues like stunned myocardium, severe LV dysfunction, Takotsubo's cardiomyopathy that can happen. You can have sort of neurogenic pulmonary edema and ARDS. These patients, as I said earlier, are also at risks of DVTs. And in terms of neurological complications, the most feared ones are the issues of vasospasm and delayed cerebral ischemia, hydrocephalus, seizures, and as I said, rebleed, which is quite bad. So coming to delayed cerebral ischemia and vasospasm, it's very important to actually accurately know the definitions of these two entities. So DCI, it's a neurological deterioration, which is related to ischemia, but it's not related to the treatment of the aneurysm. So it's not related to the fact that the patient has just had some intervention and has had some deficit. It's not related to that. It should persist for more than 1 hour, and there should not be any other confounding factor causing it. So there should not be any evidence of hydrocephalus, seizures, or metabolic encephalopathy, for example, sort of related to hyponatremia. Vasospasm, it's purely a radiological diagnosis. It's arterial narrowing, which is demonstrated angiographically or with a Doppler ultrasound. And it can correspond to some clinical symptoms or signs, but it can be asymptomatic as well at the same time. So in terms of what happens and why we see patients with these delayed cerebral ischemia or vasospasm, the delayed cerebral ischemia is believed to be due to a combination of various factors, out of which vasospasm is just one of them. But there are other issues as well involved, which are like, for example, we see in this figure, there is a lot of vasoconstriction happening, there is microthrombosis happening, and there is lots of vasoconstriction which can happen at microcirculatory level, which can cause delayed cerebral ischemia. So it's vasospasm by itself is not the sole reason for DCI. DCI can happen in the absence of vasospasm as well, and that's what is most important to know. In terms of incidence, between the two, the incidence is about sort of 60 to 70%. This is a delayed complication of a subarachnoid bleed, typically occurs between sort of 7 to 14 days. And as I said earlier, vasospasm is not the only cause for DCI, and it does not always lead to DCI. It can still be there and be completely asymptomatic. However, if the patients do have symptoms, it is seen that they're present with various neurological deficits and altered neurology, and you just have to corroborate that with imaging and find out the territory that is affected. How to diagnose? I mean, we can use clinical exam of the patient, which obviously is very difficult in this group of patients because they are sort of intubated, ventilated, and sedated. So it's difficult to delineate the deficits from an altered neurology, which is there from the beginning. In that case, you have to use various other modalities. So the ones commonly used in neuro ICUs, as far as I know, is TCD is quite commonly used apart from CT angiogram and DSAs. TCD is useful in the sense that it is a bedside investigation. Many neurointensivists are sort of have become more and more well versed in using that. But then there is a lot of inter-observer variability in terms of how you diagnose a vasospasm with TCD. And again, you only can sort of image the large vessels. You're not actually looking at vasculature further higher up in the cerebral circulation. The gold standard is still digital subtraction angiogram or CT perfusion imaging to accurately diagnose these problems. If you're working in a neurointensive care unit, you might sort of see things like brain tissue oxygen monitoring, cerebral microdialysis, and continuous EEG. I'm not worked in a neuro ICU for about sort of 3-4 years now, but I have seen that these things do exist in neuro ICUs, but they are mostly on a research or a trial basis. But you would see them at some point if you're working in neuro ICU, which is a high volume center. Again, and each of them by itself might not contribute to the diagnosis, so you can actually cumulatively take the results of various diagnostic modalities to diagnose a DCA or vasospasm. So how to manage these? Again, maintenance of volume status is important, so maintaining euvolemia, normonatremia is best. And by far, the one single modality or treatment that has proved useful is the administration of calcium channel block or nimodipine, which should be sort of given right at the beginning when you actually diagnose the subarachnoid bleed, and it should be given for about 21 days. The duration of 21 days is because after 3 weeks, the incidence of vasospasm and actually diminishes significantly. So you can actually evaluate the patient at the end of that period whether you have to continue that or not. But by far, nimodipine is the single most sort of effective treatment modality which is used in managing these patients. The mechanism of action is actually not clearly known and on how it sort of ameliorates the DCI or vasospasm, but we do know that it does make a difference. The other things that are useful are again sort of managing sort of volume status, maintaining normoglycemia, normothermia as before. They are equally important because you don't want to exacerbate the brain injury that's already happened. Avoiding anemia is equally important. And in terms of doing other things, always when you're dealing with a patient who's got a delayed neurological deficit, you should not just focus on the fact that it could be delayed cerebral ischemia, because you have to always rule out other factors as well. So other factors as in, is the patient having a seizure? Has the patient got hydrocephalus? Does he need imaging? They're all important. Is there an issue with infection that you're dealing with? And is there a septic encephalopathy that is evolving? So you need to simultaneously rule out all these factors as well. And not just focus on just DCI as the cause for a neurological deterioration late in the phase of a subarachnoid bleed. But once you have ruled out everything else, nimodipine is one thing which is definitely useful. And if you're still not sort of seeing any sort of positive outcomes, you just sort of have to resort to other measures like angioplasty, balloon dilatation, and intra-arterial sort of vasodilator injections. At this stage, it's also useful to know that all the other treatment modalities like magnesium, statins, triple H therapy, which you might have heard of, there's no benefit of any of these. And by far between sort of, if you look at the triple H therapy, as in hypervolemia, hemodilution, hypertension, the only H that is probably beneficial is hypertension. So once you've secured the aneurysm, you can actually allow the blood pressure to run a bit high, and you can use noradrenaline to achieve that. So DCI kills. It's important to sort of respect it, treat it, and avoid it if you, at all possible costs. Other neurological complications that can happen are hydrocephalus. Again, the incidence is about 15 to 85%. So always suspect hydrocephalus when there is a clinical decline after a good initial recovery. This complication can happen early or late, but it is easily diagnosed with a CT scan, and it's sort of effectively managed by doing a CSF diversion, either with a lumbar drain or an EVD. And some cases actually also require a permanent diversion like a VP shunt. In terms of who is at risk for hydrocephalus, patients who've got significant intraventricular hemorrhages, posterior circulation aneurysms, patients who have been treated with tranexamic acid in the initial phase, they're all at risk for developing hydrocephalus. Other problems, so seizures, about sort of 6 to 18% of patients can present with seizures at the initial stage, but when seizures happen later on, always suspect a rebleed and do a repeat imaging to diagnose a rebleed. The risk factors for seizures again are patients who've had clipping as opposed to coiling, because it's a more sort of invasive modality of management. Poor grade, high grade sort of subarachnoids, again high risk of seizures, and always sort of doing EEG to rule out non-convulsive status epilepticus, because that is a marker for poor prognosis. In terms of how to treat seizures, you can use anti-epileptic drugs. There's no sort of evidence to suggest that one is better over the other. The most commonly used drugs are phenytoin, Keppra. Phenytoin by itself is not a harmless drug. It's got a lot of side effects of its own. And in terms of the duration, again, treat seizures for about sort of 3 days. And if there's no evidence of seizures, there's no need to actually empirically continue any anti-epileptic drug treatment. And always assess risk for benefit when you're sort of continuing anti-epileptic drugs in these patients. Hyponatremia is quite commonly seen. It's present in about 50% of cases. The usual causes of hyponatremia are either a cerebral salt wasting syndrome that can happen, or sort of situation of aSAH, which is equally common, or you've just managed the patient sort of probably erroneously by giving lots of hypotonic fluids in the initial phase. Whatever the cause of hyponatremia is, it's difficult to actually delineate the causes between aSAH and cerebral salt wasting in this patient group, because both of them present with hyponatremia and have a high urinary sodium. But what can sort of clinch the diagnosis is possibly volume status, because patients who've got cerebral salt wasting are typically sort of dry and hypovolemic. Having said that, if you're erring on the side of making a diagnosis of aSAH, you should be extremely cautious in fluid restricting these patients, because that can actually be harmful and compromise cerebral perfusion. So you can use hypertonic saline. You can use fludrocortisone, which has sort of a slightly sort of more favorable risk profile when compared to other steroids, but usage of vasopressin receptor antagonists like Vactans, they're not recommended, because they can cause dangerous hypovolemia, which can lead to compromised cerebral perfusion. The other complications that can happen are cardiac. Obviously, as I said, subarachnoid bleed by itself can give rise to a profound sympathetic outflow, which can cause cardiac dysfunction. This is largely reversible, but can sort of lead to a patient who is quite hemodynamically compromised. And you can actually sort of diagnose that on the echo. The patients might have significant ECG changes, as in STT segment changes or regional wall motion abnormalities on echo. Treatment is usually supportive at this stage, so you can actually sort of resort to sort of doing some cardiac output monitoring if that is the practice in your ICUs, or sort of use agents like milrinone, dobutamine, and if you're sort of faced with a patient with severe LV dysfunction, sometimes you might have to resort to a balloon pump as well. So in terms of how you're going to prognosticate these patients, as I said, about 25% of these patients die before reaching hospital, which is why this is quite a serious problem. but the most sort of important factors in terms of prognostication is their neurological status when they actually present. So if you look at the various neurological gradings that we've seen earlier, survival drops from 70% for a grade 1 Subarach to 10% for a grade 5 Subarach. So if you're obtended, then you are actually in the high risk group. Aside that, the other predictors or poor prognosis are a high grade Subarach, old age, patients with more comorbidities, lots of blood on the CT scan, and patients who've got symptomatic vasospasm. All of these are predictors of poor prognosis. So that's about Subarach. And just to conclude, just sort of put an example of a FICM question, which is actually a real question which has appeared in the exam. This is an OSCE question which has appeared. This has appeared actually in my exam, wherein I was asked to interpret a CT scan with subarachnoid bleed, and I was asked to grade the subarachnoid bleed on that CT scan and how and sort of important points on managing. And then they went on to actually show some pictures of cerebral angiograms and asked me to locate the positions of the aneurysms anatomically. There was also an image of a digital subtraction angiogram, and there was a question on what the investigation was and what was the location of the aneurysm. And finally, there was a CT scan showing lots of scatter artifacts and also patients who've had decompressive craniectomy and had a Subarach. So I tried to cover most of these topics in this sort of in the presentation, so that if anyone is sort of giving the FICM exam in this group, it would be useful from an exam point of view as well. Thank you.
Thanks, Ravi. That was really comprehensive. Does anybody have any questions?
And it looks like they've not understood anything or understood it perfectly.
There's one question that says, is it worthwhile to screen people with risk factors by scanning them, since it's a potentially fatal event?
Well, you have to sort of do that on a case-by-case basis. But if someone presents with a sentinel headache and they have risk factors, it's probably wise to sort of scan them at that point, because the mortality is quite high when you miss a sentinel bleed and the patient's present after a few weeks with a big Subarach. But it's easier said than done in an ED situation.
Anyone else?
None from here, I don't think.
Anyone from the Royal?
None from the Royal.
Cool. Well, thanks, Ravi.
Thank you.
So I'm Dr. Wahab, one of the SSS trainee in LRI. Yeah, this paper is the effect of systemic ICU triage on long-term mortality among critically ill elderly patients in France, aSAH-2. It is a randomized controlled trial. So the contents of our talk, we will see what is the clinical question we need to answer, background, if there's any studies done before, the design of the paper, statistical analysis, the setting, population, and the intervention and control group, the outcome, the strengths and weaknesses of the study, and the conclusion. So the clinical question in critically ill patients aged over 75 years, does recommendation for systemic ICU trial compared with the standard care reduce the mortality over 6 months, period. In regards to the background, so the aging population, as we all know, has led to increased demand for both hospital admission and for intensive care admission. And it is not clear before that if ICU admissions benefit this population, as there is no any randomized control trial done before, all the observational trials have reported the mixed results. So there's no good result to support ICU triage or not to triage, or just to use the standard guidelines or the standard approach by ICU physicians. So the design of the study is a cluster randomized control trial, computer generated randomization. So they are just allocating hospitals, one of the hospitals to run the, let's say, some of the hospitals to run the intervention group, and the other hospital to run the control group. It is stratified by median number of emergency department visits previous to that, but in a given geographical area. And those patients who are admitted to ICU, they need to be followed for 6 months for the mortality and for the another secondary outcomes. So the statistical analysis is about 2,800 patients required to have a 74% power to detect at least 6% difference in mortality from the baseline in the previous studies. Baseline of 32 mortality in the standard group. So it is intention to treat analysis, and the hospitals involved are 24 hospitals, and the number of patients at the end. So because the hospitals they increased from 20 to 24, the number of patients needed are around 3,000 patients, and at the end they recruit about 3,036 or 37 patients in this study. So it's quite a large number of patients. It is a bivariable association, evaluated by using the T-score, and also for the continuous variables, they use the Fisher exact test for categorical variables. The binary outcomes analyzed using a logistic regression models. The crude overall survival at 6 months is estimated by Kaplan-Meier method compared with log-rank test. The 6 months survival adjusted for baseline characteristic estimated by using the Cox model, because they didn't check only the crude overall survival over 6 months, but they have adjusted that according to the basic characteristic of each patient, and they use the Cox model for this one. So as we have said, 24 hospitals, it is all in France. There is academic and non-academic hospitals, and in each hospital there is at least one emergency department and one ICU. The data collected from January 2012 to till November 2015. So the inclusion criteria, the patient age has to be equal or above 75, presenting to the ED, with a predefined critical conditions that potentially require organ support or ICU admission. They have to have a preserved functional status. So the index of independence in activity of daily living score above or equal 4. And also they need to have a preserved nutritional status. So they're excluding any patient with cachexia or he has any preserved nutritional status. And also the patient has to be free from active cancer so that it will not affect the mortality, or there will be a bias in regarding counting the number of mortalities in these patients. The exclusion criteria, any ED stay of more than 24 hours, any secondary referral to emergency department, and if the patient refuses to participate. So the number of patients randomized for this trial, 3,037 patients, 1,519 in the control and intervention group. So, and there is one from the intervention group. He withdrew his consent for continuing the trial. So, ending up 1,500 patients, 1,518 patients in each group, in the intervention and the control group. So, comparing the baseline characteristic of intervention versus control groups, patients in the intervention group had a higher recruiting rate. So those who have the intervention group, they have recruited earlier by about 6 months from ending the trial. So the trial ended in November 2015, and they are waiting for the control group to complete the number of patients. So those who have the intervention, they recruited in a higher rate. So in the intervention, the program to remote ICU admission, the ED and ICU physician, they have asked to systematically recommend an ICU admission for all patients in the intervention group. The ED physician required to systematically call the attending ICU physician, and the ICU physician also, he will require a systematic evaluation for the patient at bedside. And both of the physicians from the ITU and from the ED, they have to sit together and to decide jointly to admit the patient to ICU. If there is no any ICU bed available, the patient to be transferred for another hospital with ICU. But if that is not feasible, the patient ending up admitted to the either intermediate care or specialist unit. So there is 62% of patients admitted to ICU and 16% of patients admitted to intermediate care or specialist unit. And in the control group, the standard care, there is no recommendations regarding the ICU tryout. So just the usual way of admitting the patient to the ICU they have used. And the decision for admission is just made by the physician at bedside, either the ITU or the ED, but they don't need to jointly decide if they need to admit the patient. 34% of patients admitted to ICU here in this group, and 21% admitted to intermediate care of a specialist unit. So the differences in managing between two groups, in intervention group, physicians inquired significantly more often about the patients, and also they have run a surrogate decision maker's opinion about the ICU admission. 49% versus 24, with a p-value of less than 0.001. The ICU physicians more often involved in trial process in 97% versus 62 in the standard group, and also the ICU physicians were more favorable to admit the patient to ICU in 75% versus 56 in the standard group. Patients were more favorable for to ICU admission in 88% versus 66 in the standard group, with a p-value also of less than 0.001. So, in regards to the outcome, the primary outcome, which it will answer the clinical question of our study in regards to the overall mortality at 6 months. So the crude mortality significantly higher in intervention group is 45% versus 39 difference of about 6%, which is the aim of the study. But when they adjusted that to the baseline characteristics, there is no any significant difference between the two groups. In regards to secondary outcomes, so the ICU admission significantly higher intervention group. So in the intervention group, they admitted about 61% of the patient versus 34. This one to ICU in regards to the standard group. And in hospital mortality, significantly also higher in intervention group. 30% to 21%. In regards to decrease from baseline index of independence in activities of daily living in 6 months, significantly greater in intervention group also. So, the median difference between the follow-up and the baseline score is higher in the intervention group. They have run also post hoc analysis for those patients, so they compare the treatments given to patients admitted in the intervention group versus control group. There's 374 patients versus 147 underwent mechanical ventilation, and also 251 versus 170 in the tunnel group. They have underwent also non-invasive ventilation. ICU and hospital stay, there is no significant difference between the two groups. And also, the patient discharged alive had increased lengths of hospital stay. So those who have discharged alive, they stayed more in the hospital, 16.8 versus 13 in the standard group. And also they have run a self-reported physical quality of life at 6 months. There is no significant difference between the two. And also self-reported mental quality between the two. It is not that significantly higher, it's 44.6 versus 43, so it's almost the same. So if we come to the strengths of the study, it is a randomized control trial, and it is a first randomized control trial. It's run in France. I'm not sure if there is any study like this run here in the UK or other areas of the world. But it is a multi-center. There is a large number of patients randomized. The significant difference in ICU admission rate achieved between intervention and control group. There is a significant difference. The weaknesses, so the recruiting rate was lower in control group, suggesting maybe a selection bias, or it is because it depends on how is the hospital run or how is the ICU run in each hospital. So we can't judge in that area. But also there were significant differences in baseline characteristics of the patients. So this one also may affect the study. The trial was set in only one country, so it is just run in France, and the ICU admission may differ from country to country. So it is also one of the weaknesses. And also the use of cluster randomization means that systemic difference between hospitals may have accounted for some bias in the results. So the author's conclusion in critically ill patients, in critically ill elderly patients, a program to promote systemic ICU admission increased ICUs, but did not reduce the mortality. So there is a higher recruitment, but the mortality is not affected. And I think I also agree with the author in that. And in my opinion, just to go with the standard, just to maybe to enhance the criteria for admission. So just to put standard guidelines as we have here in the regarding to admitting patients. So any comments or questions, please?
I have a question. So does they the difference between two groups. This group was triage in some hospitals or some centers, and some centers not triaging with ICU.
Yes.
Or
Because they're not running the two studies in the same hospital. So they are asking some hospitals to run the intervention group, and that's why it is a cluster randomization. So they're randomizing the.
They randomize in the centers.
Yes.
That they are not going to do ICU triage for all patients, or just the patients that with query of ICU or not.
No, so in regards to the intervention group, they are asking a systematic triage between the ICU physician and the ED physicians. They have
for all the patients?
For all the patients need to be admitted to the ICU. For all the patients meeting the criteria for inclusion. Because there is a defined criteria. Any patient meeting the criteria, they have to do that in each patient.
But not all the patients in ED?
No, no. Those who are meeting the criteria.
So this study concludes that the ICU triage is not helpful with the mortality that they
So the mortality rate is the same. There is no significant difference between the mortality between the two studies. Especially when you adjust it to the baseline characteristic of each patient.
That's fine. In this study for ICU triaging or not only, or ICU interventions, whatever the ICU intervention is?
No, it is only for ICU triaging. So they have run secondary outcomes, but the main study, the clinical question of the study is to see an ICU triage with this way, which is joined between the ED physician and the ICU physician, is significantly decreasing the mortality in 6 months. But the result is there is no significant change between the two groups.
Wahab?
Yes.
As a medical trainee, how do you think that affects your career and your decisions about whether to escalate your patient's care to ITU?
So, in regards to the study itself, it is really interesting study, but I think defining a criteria for ICU admission. When I read the first the first guidelines, or the first protocol which you have sent to us at the beginning of this shift in ITU in August. I think, given that there is a special criteria for those who need support, needs to be admitted to ICU, it will help the trainee at least what to look for and what to when we go down to the A&E. But in regards to the study itself, so when you have sent it to me 2 days ago, usually I am not reading each study in details, but I think it's good for us to look at this here, and it is helping us in at least have an idea about who needs to come to ITU and what we need to do for him.
Good. Dr. Charlton, you had a comment?
So I was just going to say, given that when ICU review was mandated for the over 75s group, all it essentially did was increase the number of them that came to ICU with a slightly worse mortality. Do you think, therefore, that the medics are better at picking which patients should be referred to ITU than we are?
Yeah, so because they have admitted any patient meeting the criteria, and the mortality is higher when they have when they have adjusted to the baseline or before in the crude results. So I think in the study also I read about the, who is the physician who done the triage, and also the seniority of them and all of that stuff. So I think that's affecting, if you are admitting any patient over 75 to ITU, we will increase the mortality, and I'm not supporting that, given that the patient may get better if he didn't come to the ITU. But I think there's, we need to look at how many systems needs to go to be supported, and at that time decide, yeah, to admit the patient or not. But I don't think so admitting any patient above 75 is, if he can be managed far from the ICU, if I get your question right.
Yeah, sort of.
Yeah.
Any questions from you guys? Well, thank you for that.
Cool. Thanks, everybody. Hopefully you can see that QR code. I think.
Yeah.
Cool. I put the link on as well so that you can do it if you're watching on your phone. Next week is Dr. Jeanette Gross, who's one of the anaesthetists at the General. She's also Deputy Medical Director of ITAPS, and has an interest in QI and human factors and stuff. She's going to talk to us about human factors and locations, and including certain incidents that have happened on the intensive care in the last couple of years. So that should be interesting. Thanks, everybody.
Thanks, Ollie. See you later. Bye, everyone.
Yeah.
Thank you.
Thanks, Ravi, so much.
Thank you.